Good morning. I'm glad everybody could wake up today. Everybody have a good weekend? Let's get that out of the way. Happy to be back, right? Oh, yeah, there's some enthusiasm there. Okay, I don't have the clicker, so I'm going to be standing here. So if I'm blocking anything, okay, thanks. Okay, disclosures. Anybody want to give me any disclosures? Darn, okay. Thought I'd ask. Okay, so post-surgery. Most of us have talked a lot about surgery in here and what happens to that point. What happens with the patient once they're discharged from surgery? That's what we're going to focus on. There's multiple options. There's acute rehab, skilled nursing facility, home health with health services, and return to home without home health. That goes along with assisted livings. If they live in an assisted living, they can have home health come to them, or they don't need it. Usually before we even get to the point of discharge, providers, case management, therapy, nursing, families have all determined the safest discharge plan on where they're going. The decision's based on mobility, cognition, caregiver support, the home environment, and overall medical complexity. So, when patients are discharged with home health versus without services, what does home health consist of? Nursing, physical therapy, occupational therapy, social services, CNA, disease education, medication management. The interdisciplinary team works together to improve function, manage chronic disease, prevent complications, and support independence while reducing rehospitalization risk. Home health is most appropriate when patients require skilled intervention, however, are still safe to remain in their home setting. This includes post-surgical recovery, chronic disease management, wound care, medication, teaching, and monitoring for decline. So we've got a few cases that we're going to go over. And I'm going to ask you guys' input because I don't like just being the one standing up here. So we've got David and James both present with a similar clinical picture. They're both 70 years old. They both have a wife as a caregiver. They're both undergoing a right total hip surgery. David is sent home on home health services, while James feels that he doesn't need any home health services. He's strong, he's independent, he might be a little stubborn, doesn't feel like he needs the care, he can do physical therapy on his own. Okay, so we've all seen these patients, right? Okay, so what are some of the factors that we're considering when they go home? Anybody have any ideas on what we're considering on what might be issues that we're encountering when they go home?
Pain management, bone infection. How good they were before doing their exercises and things like that before their surgery.
Okay.
Ability to perform activities of daily living.
Yes.
I usually ask if they have stairs in their home, and then if they were able to practice that in a hospital and how they did.
Excellent. Anybody else? Any other things to consider? I didn't hear any rugs. Stairs to get in. Safety. Do they have access to a bathroom or bedroom on the main level? Are there stairs going into the home? Do they have clutter? Do they have animals? All things that home health considers, looks at when they go in. They educate on how to be safe. Any other things to add to this? No? Okay. Okay, so how did David and James do with their recovery? Who wants to take a stab at it? Oh, come on.
I would assume that David did much better with recovery because he got the help that he needed. And we were able to get him into the community after home health, into a outpatient physical therapy clinic to continue that home health. Whereas James more than likely had complications, wasn't able to get the range of motion that he needed, and I would be extremely concerned about safety.
I think you just said my next slide. Anybody else have anything to add on to that?
I would also suspect their wives were in different places too, because the burden of care was dramatically different between the two cases.
Yeah, I love hearing that. So I'm going to take a step back. How many of you have had surgery personally? How many of you remember how you handled it going home the first week? How did you do on medications? Did you need a spouse, a kid, a parent to help you in that first week? Most people are nodding yes. Most people are nodding yes because the medications affect you, right? You're not as safe. Even if you feel like you're safe and you're taking those medications, just being able to manage those medications every 4 hours or every 6 hours. I know I took care of my husband after shoulder surgery. He could not put one, he had no idea which pill he was taking. Thank goodness I handed him the pill because he would have been in trouble. So you take that and you add age factor, 70 years old, still young. Let's say they both play pickleball. They still want to get out on the pickleball court. Pickleball's the new rage, right? They're still young. They're still active. They still are cognitively there, but that medication affects them.
I have a question for you.
Yes.
Do you think James had any sense that it wasn't going well? And was there any sort of chance for intervention if he had refused this home health care?
Yes, I do feel like so these are two cases that I've actually seen. They're kind of put together, but he went in 2 weeks, post-op, doctor's appointment, was offered it again and declined and said, oh no, I'll get back on track. That's a great question though, because if the patient is willing, and I feel like in that case as well, it's the education aspect on why is this important and how can this get you back on track, not just this is what you should do, or we're all busy. When they go in for post-op appointment, it's in and out. So, yeah.
I think a lot of this goes back to having been a home health nurse for years and now as an MP in that area. A lot of people, when they refuse home health, at least what I see, is that they've had a bad experience with it before. Mm-hmm. And they've said, like, well, home health doesn't really help me. Or this just didn't go well the last time, or I didn't really need it. And I think the kicker to providing home health for patients is it comes down to that provider that's referring them to home health. What is their experience with home health and how do they feel about it? Because they can really make that difference to teaching and educating these patients that home health is actually, the outcomes that we see with home health are much better, especially for somebody like David than James. And those providers that I've worked with in the years past that actually promote home health and actually educate in that initial appointment make all the difference in whether that patient feels like they need home health. And it's different. Like the home health now versus the home health 10, 12 years ago is different. It's not the same. Yes. But people have a thought process in their head that, oh, I had this 12 years ago and it didn't do anything for me. And so I really think if we are personally, if we are not providing home health options to our patients, I think we're actually doing them a disservice.
Thank you. I couldn't agree more. Like I am such a huge advocate for it. Along those lines, it also goes along with the communication and relationship with physical therapists, nurses, doctors. So that communication factor is key. That's why I like rounds, because everybody communicates and discusses the patients. Okay, so let's see how they did. So James, he ended up going to the ER on day 5, refused home health. Said, oh no, I'm good. Medications were uncontrolled, taking only when needed, and he was unable to get ahead of the pain. Range of motion was limited. Struggled to follow surgery precautions. Okay, so that's a slew of problems right there. 4-week post-op appointment, range of motion's limited. He doesn't have a normalized gait. 3 months post-op, James has just started outpatient therapy. Outpatient physical therapist, how do you think he's gonna fare? Come on, there's a few of you in here. How much work is it gonna take to get him back to a functioning level?
These are difficult patients because when they come in, you're just like, oh, great. Now I'm shoveling a pile of sand while I'm trying to go uphill on a pile of sand. It's like it just keeps falling back. Yeah, I mean that's a challenging situation. They're delayed already. It depends on range of motion. This is total hip. I'd be more concerned if it was total knee.
Yeah.
Total knee would just be stuck, and I'd have to call the doctor and just like, what are you expecting me to do here? Setting expectations would be that. I said one thought I want to follow up on what Steve had said. I think that some, especially patients that are in 60s and their 70s, their only experience in home health is watching somebody in terminal care.
Yeah.
Yes. Yeah.
Right.
I agree.
So their experience is hospice. And they're like, so I'm going to give you home health. I'm like, hell no, I don't want hospice.
Yeah.
I don't want somebody who's just going to sit and read a book in the corner. Right, because that's their vision is 24-hour care or just a nurse who's in their house. They don't understand really what it does, and so I think we just have to kind of take that perspective. It's like, this is really what the job is.
Yep. So that education, and with that said, home health in this case should only be in 2 to 3 weeks because they're driving at that point. So setting that expectation and that the education for the patient is also another very important factor of, no, home health is not here to take the role of outpatient physical therapy. It's that bridge from surgery home to outpatient therapy. So James has a tough road ahead. Okay, let's compare that to David. Had 3 weeks home health physical therapy visits, 3 visits from a nurse, medication management, pain management. Pain was controlled, safety was gone over, no issues in the home, no falls. Falls are a big risk. He was discharged to outpatient physical therapy at 4 weeks. The physical therapist coordinated that transition to outpatient therapy with the outpatient therapist. 3 months post-op, patient's driving 3 weeks. So 3 weeks, range of motion is within normal limit. 3 weeks versus 3 months, big difference. Pain's controlled at 3 months. David's happy with the surgery and outcome of his total hip replacement. We've discussed the differences. It's obvious. Anybody have anything to say about the differences? Anything else? Yes.
I do have a question that's not really about the differences, but about the reality, whether it's there or not, that home health care maybe doesn't work sometimes. And maybe it's not just about their attitude, but there's something about their physiology or the surgery or something. Can you speak to that a bit?
And sometimes it doesn't. Sometimes it is. There's been times that I've gone into patients, and actually one I'm thinking of specifically, the surgery, I don't want to say it was a botch, but she ended up going back in 3 months later. And so when I was in there, it was a total knee. swelling, edema, ended up having an infection. She did end up going back to the ER because it was really bad. I was in there and I said, "There's, we've got to come up with a better solution." She'd called the surgeon. Luckily, it wasn't anybody in this group. Just gonna say that. He's actually now retired. He didn't really give her a clear line, a clear path to go. So she ended up back in the ER. They controlled the infection. She went back into surgery for a revision, came back out, and then actually home health did work because the infection was cleared. So there are those cases. There are cases where home health will not work, and you have to be willing to look at the circumstance as a provider and say, okay, this isn't working. What do we need to do? Where do we need to go? What resources can we do to help that person?
In that case that you're talking about, even if the therapy is not getting the range of motion or whatever because of all these other things, I think it's important for home health to be in there because it's another set of eyes. Patients just don't know what to look for. They look at it and like they may have some redness and they're like, oh no, it's infected. And as clinicians, we've seen it enough that we can say, no, that's normal. It's normal to have some swelling. It's normal to have some redness. Or yeah, that's an issue. Let's contact your provider. So it's just another course for people to have some backup, I guess. Yeah. Even if the process isn't going as planned.
Completely agree. No, love that point of view.
And it's much better to have home health in there when it's not going to work than have the patient be on their own, not knowing what they're doing with the situation there as well.
Yes.
We have our thought processes and our education to rely on to help make those decisions on what's working and what's not working, and when we can move on to the next step, whether that's going back to the doctor or moving on to outpatient physical therapy.
Very true. And in that case too, the nurse was involved. So home health was necessary because the nurse came in and she's the one that said, hey, we need to get you to the hospital in this case. So even if it is not working or going according to plan, I love that point of view. It is better to have those eyes on you than just being completely left alone. Trying to call your doctor, not getting through, waiting 24 hours to 48 hours for a response. So, okay. Okay, sorry, this is kind of a mess, but so this number is staggering to me. $40 billion in annual health care spending can be attributed to hospital readmissions. That's just readmissions. 40 billion. Crazy to me. So higher continuity of care with discharge planning and closer follow-up has been found to reduce complications and readmissions. This study was done in 2018, and it also said that the continuity of outpatient and inpatient care has decreased in recent years, which is very interesting, and it led me to a discussion I had with Steve about home health to outpatient and where we're missing. Cost savings per patient of just over $15,000. Home health independently decreased the hazard of follow-up readmission and death. Discharge with home health care was associated with significant reduction in healthcare utilization. And then the next article is specifically on hip replacements. After adjusting for regional variations, the likelihood of patients not being seen by home health services are twice as likely to have readmissions to the hospital. Those are just kind of stand out research papers. There's tons out there. If you get bored, look some up. It's fascinating. But after going over these 2 cases, you can see where those numbers come from and why those happen. Okay, so not everybody qualifies for home health. So when you're looking at this, these are the requirements. Leaving the home requires considerable or taxing effort. The patient needs an assistive device or help from another person. The patient leaving the home is medically contraindicated. So when you are talking home health, make sure that those conditions apply, because if they're driving to the grocery store and driving to visit kids or pick up kids, it's not indicated, and then the best approach is they're going to outpatient therapy. So, home health helps with the continuum of care. We've got the doctor's appointment. We all have our pieces here, and it's important that everybody communicates. I'm preaching to the choir right now. I'm preaching to the choir because everybody communicates in this room. It's the doctor's visits, it's the surgery, then home health, then outpatient, and then hopefully they're leading a happy, healthy life. So home health can help bridge the process from inpatient care to outpatient clinics. It's important to have communication and education throughout the care process. We never want to leave our patients without help and feeling alone. That's where home health comes in. They're not just stuck in those 2 to 3 weeks feeling alone. As care providers throughout the patient's experience, we should feel encouraged to help support them live their best lives. Home health is another tool for better outcomes and success. So I just want to leave you today with the thought of letting home health be that bridge and that direct continuum of care through care you provide to support the best possible outcomes for your patients. Any questions? Yes.
I've had 2 patients who their home health PTs were not very good in my eyesight. Like the range of motion wasn't there, even though they were continually saw by the therapist. They did their exercises, but the exercises were not up to care. So I'm curious on either your side in leadership in your company, but also the doctors. Like, is there a time that you guys would switch, say, hey, go to another home health therapist? Like, what do you guys see on your side? Because like an outpatient, I see it, and it's like, ooh, they did not do what they were supposed to do for the last 6 weeks.
Can I ask a question on that? Did you let the company know?
No, that's a good question.
Okay. Yeah, I would talk to the company because oftentimes the protocol doesn't they don't look at the actual protocol. And so I would talk to the company and just ask who the physical therapist was, what if they adhere to the protocol, and maybe get a different perspective. And the patient, one thing too is the patient always has choice. So regardless of, sorry doctors, regardless of who the doctor says you should go to this company, the patient does have choice. So if the patient's neighbor says so-and-so is good, they might go with so-and-so instead of who the doctor's preference is. And that can play into things too. And not all physical therapists are great. I hate saying that, sorry, physical therapist. Just like not all doctors are great. So doing the research, making sure that they are getting that care, but I would definitely reach out to that home health company and talk and have a conversation and say, hey, I didn't see this. And then maybe there's a reason why that happened that you're not aware of, that's not in the notes. What type of notes do you get from the home health agency? Any? Yep. So I would give them a call and say, hey, what did you see during this? Because there might be something that you're completely unaware of.
Along those lines, I'm wondering, are there metrics that like home health is measuring to ensure that there is progress? Because yes. the patient is not going to know if they're on track or not.
Yep. There are documentation, it's documented range of motion, strength, all the physical therapy measures, all the nursing measures. In order to get paid, we have to document everything. So we are documenting at each visit what the progress is. If there's not progress, why that's happening. So that actually brings up a great point. Like, why is the home health care company not providing those notes to the outpatient clinic? So that's a valid point. Yes.
I think it brings up again what you had said earlier, what we have talked about is there is a disconnect between home health and outpatient physical therapy. I see a lot of cycles in my patients, so my patients are all geriatric in skilled nursing facilities, and I see a lot of cycles in where I'll see similar patients 2-3 months down the road. And I'll be like, okay, the last time you were here, I sent you home with home health. What happened afterwards? Mm-hmm. I went with home health for 4 weeks, and then I just was at home. And I was like, you didn't go to outpatient physical therapy? No, I didn't go to outpatient physical therapy. Why not? Well, either A, home health didn't tell me, or B, it was too much of a burden to drive in, or whatever. Things happen, right? But I feel like, and this is something I've been working on for a while now, trying to get that connection between home health and outpatient physical therapy. You know, ideally, in the perfect world, it would be that they go to home health for 3 to 4 weeks, and then they have already been connected to an outpatient physical therapist in the community who is monitoring that progress and is willing and able to take over as soon as they end home health, so that continuum of care goes. And then they can, because we're talking, you know, a neurosurgery, 6 months to fuse solid, they go to home health for 3 to 4 weeks. What are they doing afterwards, those 3 to 4 weeks? A total knee range of motion, 3 to 4 months. What are they doing after those 3 weeks? Are they doing those exercises on a daily basis? Exactly. Sometimes they are, sometimes they aren't, depending on cognitive status. So that, I feel, is a huge disconnect between doctors' offices, home health, and outpatient physical therapists.
I agree.
Something we need to work
and we're going to work on that.
We are working.
We are working on that now. I love it.
This is what is very important in home health, that you provide outcome reports. So if the patient is in service for 3-4 weeks, you want to give outcome reports to the doctors and even to the hospital to see how the patient is progressing. And then answering for the physical therapy, you have to have short-term goals and long-term goals. And that's the way that you achieve those things, and you coordinate with the outpatient therapy. So when you have that disconnection, that's when all these things happen.
Excellent point. Yep. Okay. Well, thank you guys for your time. I hope you have a great week. If you have any questions after, I'm around.